Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center of Miami with our Monday afternoon Instagram chat. I apologize for being a few minutes late getting the internet working here. But today's topic is understanding semen analysis, what it means and how do we treat it. So, as you know, when we're looking at an infertile couple trying to figure out why they're not getting pregnant, we do some different testing on both members of the couple. On the male side, the single most important test, other than taking a medical history, is to perform a semen analysis. To do this, we need the male partner to collect a sample of sperm. The last time you should have relations or there have been an ejaculation should be a minimum of 2 and a maximum of 3 days. Technically, we can do a semen analysis at any time, and if the semen analysis is normal, that's totally fine. But if the semen analysis is abnormal, the abstinence interval from the last time there was an ejaculation becomes important, because if it's too soon to the last ejaculation or too far from the last one, you can get an abnormal result that doesn't necessarily imply that there's a problem. So the best thing is to time getting us a sample with at least 2 and no more than 3 days from the last time there was an ejaculation. With the semen analysis, we're looking at different components of the sperm, basically. And the analysis is ejaculated usually in about 1.5 to 3 cc's of fluid. The most common misunderstanding, particularly with guys that tend to be macho, is they think when they ejaculate, they're ejaculating tons of fluid. But in essence, we're talking a normal ejaculate to be, a half a teaspoon of fluid is a normal ejaculate. So the first parameter we look at is volume. If it's extremely low volume, then, assuming that in the collection of the ejaculate, the container wasn't missed and it does need to be collected in a sterile container, then very, very low volume would potentially imply that instead of the ejaculate being emitted antegrade through the penile urethra, it can sometimes go backwards and end up in the bladder by mistake, which is called retrograde ejaculation. So the first parameter of a semen analysis is volume. Anything over 1 cc is considered reasonable. A normal volume is technically 1.5 cc's or more. The second parameter we look at is pH, less of an issue nowadays because of the way we treat sperm, but pH is usually alkaline, above 7.2 in sperm. If the pH is very acidic, sperm don't survive as well, basically. But the key, the basic parameters, when you look at it when it's first ejaculated, we look at the color, the opacity, the thickness or the viscosity of it, that's just looking at it generally. The semen ejaculate takes about 20 to 30 minutes before it totally liquefies, and at that point we can do a basic analysis. The 3 key things of the analysis are the count, motility, and morphology. So we have volume, and then the 3 key microscopic parameters are count, motility, and morphology. The count just says how many sperm are there. And you'd like to have at least 15 million sperm per cc of ejaculated fluid to be a normal sperm concentration. The motility represents, if you look at the sperm under the microscope, what percent of the sperm are moving, and then we also look at progressive motility versus twitching and just sperm that are going around in circles. We want to look at the percent of sperm that are motile versus percent of sperm that are immotile. Immotile sperm may be live or dead, but we don't want to use those. Motile sperm potentially are capable of fertilizing eggs, particularly the ones that show good progressive motility. So ones that are kind of funky, they don't swim well, they're kind of stuck in the mud, they go around in circles. These sperm don't tend to work very well. The sperm that you can see, they don't go in a straight line, they'll wiggle around, snake around, but they're moving from one place to another Those are the ones with good progressive motility, and that's important. And the third parameter that's really important is the morphology of the sperm. The interesting thing is that most men don't have a high percentage of normal sperm. If you look at 100 sperm and you stained it to look at the shapes, a normal sperm shape would be an oval shape with a single tail on the sperm. Only 4%, you only need 4% normal sperm to look like that to call it a normal semen analysis. So a normal sperm count you can have with morphology, 10 or 12% normal sperm, but anything over 4% or greater is considered satisfactory. So most sperm are kind of funky looking. And then if you took the concentration of the sperm and you multiplied it by the volume, and then you multiplied that by the percent motile, you would get a key number, which is the number of actively motile sperm in the ejaculate. And a good rule of thumb is that number should be at least 10 million. That's the number that a sperm bank would use to say, okay, this is a fertile person, we are okay using this person as a sperm donor. And you can take the same thing. If you've got 10 million motile sperm in your ejaculate, at the end of the day, you probably have adequate sperm there. So again, the key things are volume, sperm concentration, percent motility, and percent normal forms. What we're looking for are 15 million sperm per cc, 40% motility, and 4% normal forms. And if you multiply the volume by the concentration by the motility, you would get the absolute number of motile sperm in the ejaculate. We'd like at least 10 million. So if those parameters are all met, we've got basically a normal semen analysis. If you've got a low number of total motile sperm, then it's going to be harder to get pregnant. And what's difficult to tell patients who, obviously, the big question is, well, is it good enough to get me pregnant or not good enough, or do I need to do IVF, or what do I need to do to be treated? That's a more difficult question to answer, but the basic way you can think of it is that the lower the total number of motile sperm, the lower the sperm count, the lower each of those individual key parameters are, the harder it is to get pregnant, basically. Remember, a woman ovulates one egg in a month, and every time you ejaculate, you're ejaculating 10 million motile sperm. And so you need all this sperm to just have one of these poor guys find the egg, fertilize it, and do its job to fertilize that egg. Now, what do we do if it's not normal? If the volume is not normal, it's very, very low, we look for evidence of retrograde ejaculation, seeing if there's any sperm in the urine post an ejaculate. If the count is low, then low counts and low motilities can be affected by a variety of things. We want to make sure that the gentleman is not using outside hormone replacement, testosterone injections, going to the gym and taking lots of androgen supplements, using finasteride to get hair to grow back when you're balding and stuff. You just want to make sure you're not using any medications or pharmaceutical preparations, anabolic drugs that would affect sperm count. If by history there's no obvious reason, then we do some additional testing. And the testing you can do are looking for some hormones that can explain why the sperm count is suboptimal. We check for testosterone, FSH, LH, prolactin, and thyroid, the key ones being the testosterone, FSH, and LH. We're trying to see whether the testicle is being stimulated properly and is just not responding, or is for some reason is not being stimulated properly by the pituitary gland. The next thing that we're taken into consideration are anatomic issues. Is there a dilated vein present in the testicle, or is there some other anatomic lesions? Dilated veins are pretty common, but fixing them doesn't mean that you're going to improve your sperm count. So if you have a varicocele, the question always comes, should I fix it or not fix it? In about 50% of people, there'll be some improvement in the sperm parameters. But often if the parameters are very, very, very low, if you've got 1 or 2 million sperm, it's extremely unlikely for that to turn into a normal sperm count. So we've got to look at how abnormal the sperm is and what the likelihood is that it's going to revert to a more acceptable value to result in pregnancy that doesn't require any other intervention. We'll send off the hormone testing. We usually will refer you to a urologist if we think an exam would be beneficial. In men who have 0 sperm, that's another issue altogether, and then we have to figure out whether there's blockage in the system or whether there's no production of sperm. And hopefully in that case also we worry about genetic issues that can cause sperm not to be produced. And in general, if there's less than 5 million sperm as a concentration, we will do the genetic test to look at a karyotype and what's called a Y chromosome microdeletion to look at the part of the Y chromosome that codes for sperm production. So that's the diagnostic stuff that's done. That's the basic semen analysis. And then the last part of the discussion is really, what do we do about it? Obviously, if there's something that can be fixed, whether it's hormonal manipulation, putting the man on Clomid to see if the testosterone level comes up, whether there's a blockage that can be unblocked, for instance, of a vasectomy where the tube is tied and you want to put it back together. In most cases, the sperm is what it is, and usually medical or surgical intervention doesn't work very well. And so the question then comes is, okay, if my sperm count is suboptimal, what options do we have for treatment of the couple? And in this case, we're treating the couple as together to get a pregnancy rather than just treating the guy to improve his sperm count. And there are 2 basic approaches to this. The first is using ovulatory drugs combined with intrauterine insemination. In this case, you're taking the sperm and putting it up into the uterus where it's closer to the eggs at the time of ovulation, so that it's easier for the sperm to find the egg and hopefully fertilize it. Success rates are not overly great with intrauterine insemination because the sperm still have to function normally. They have to find the egg, fertilize the egg has to be transported back to the uterus once it's fertilized as an embryo, and then it has to implant. So it's certainly in men that have sperm counts that are suboptimal but not really bad. And what I mean by that, let's say instead of a sperm concentration of 15 million, we've got half that basically. But usually you want to have at least 5 million per cc of sperm with reasonable motility to do inseminations. If we wash the sperm, because in order to inseminate we have to wash the sperm, and if the sperm are really fragile and not that many of them, when you do that, you won't have very many sperm to inseminate with. So approach 1 is insemination. In general, the worse the sperm count, the worse the success is going to be with insemination. If you've got sperm counts of 10 million instead of 15 million, then we may get pregnancy rates in 5 to 10% range. But if you've got sperm counts in a 3 or 4 million range, the chance of getting pregnant is going to be very, very low and in single digits. And when you get down to 2 or 3 million, we're talking about 1% chance of pregnancy with insemination. So that doesn't sound very good, but that's where IVF comes in. Because with IVF, the good part is we no longer need millions of sperm. We're going to do IVF, we're going to stimulate the woman and get some eggs. We're going to have 10 or 15 eggs usually. In a younger person, we may have 15 or 20. And how do we get these eggs to fertilize? You remove the eggs, and then in addition to laboratory, you can actually take a single sperm and inject it into a single egg and force it to fertilize. So instead of needing millions and millions of sperm, let's say 10 million actively motile sperm for a normal semen analysis, if we've got 15 eggs, I need 15 live sperm. So even men with very, very low sperm counts, million sperm, 500,000 sperm, as long as we have live sperm in the ejaculate, we can use that sperm to fertilize eggs. And pregnancy rates with IVF, if you end up with a normal embryo, are going to be in that 50% range. So IVF is a great treatment for male factor infertility, and it's really the primary and best way and the way you should begin to think about getting pregnant. If the sperm count's off a little bit, it's fine to try inseminations. But once you get down, certainly to 5 million or less sperm, IVF is a first-line approach. Really, it should be the way to go. And certainly chat with me or your doc, and we can always give you our best advice at the time. Morphology is the more ambiguous thing to look at when you look at semen analyses, in that even if the sperm morphology is 0, it doesn't mean that it's not going to fertilize eggs, and it doesn't mean the babies are going to be abnormal or funny looking or anything else. The abnormality of the sperm has nothing to do with the DNA that's in the sperm. The DNA is fine. The issue with the sperm shapes being not normal is that they tend to not fertilize eggs as well. So in men with very, very low morphology, we're talking under 4%, it's harder for the sperm to fertilize eggs. And again, we get into how do you treat that? You can try a multivitamin that contains carnitine and some antioxidants, and that sometimes will help improve things, but that's a supplemental approach. The real key is either you do inseminations and hope for the best, or when there's 0 normal forms, one can consider going, or 1 or 2%, one should even bring up the possibility of going directly to IVF. Again, if you inject the eggs with ICSI, intracytoplasmic sperm injection, doesn't matter how low the morphology is, you're able to get fertilization to occur as long as we have live sperm to work with. So that's the basic understanding of the semen analysis. There's a lot of stuff on there, but the key things to take home again are volume, count, motility, morphology. The main thing is count and concentration, motility. The treatment is either use of insemination methodologies with a fertility drug, and the best treatment is in vitro fertilization with intracytoplasmic sperm injection of eggs. Obviously, any treatment success rate depends on the condition of the uterus, the age of the egg that we have on a female partner, and so forth. But in general, these are good rules of thumb. So have a good afternoon. I hope this was helpful, and it's my pleasure taking care of everybody, and certainly at the end of the day, we love seeing those pictures of babies on ultrasound, and when you bring back the babies, it's nice to see that we've been able to help you guys create a family, and we love our ability to share in that. So have a good afternoon and take care, guys.